Hello and good evening. Welcome to the BRCA and Hereditary Cancer Clinic workshop. Today, I'm in the company of Julie Mack, Elizabeth Lynn, and Veronica Fern, talking about genetic testing and what you need to know about genetic testing, when, where, what. And before we delve into the panel, and I let my panelists introduce themselves, I'd like to thank Danielle for the flyer and Brian for the IT help and everyone who works in the background and schedules everything. So with this, Julie, say a few words about yourself, please.
Thank you so much. I'm really excited and honored to be talking this evening. We got a chance to look at all of the questions that were submitted. I'm one of the genetic counselors. And so, as you might expect from my job description, I talk to people a lot about genetic testing, and I can see a lot of the questions are about our young children and young adult children. And I think I feel a lot both as a parent and as a genetic counselor. And so I'm looking forward to talking through some of these topics together.
Beth.
Good evening, everybody. I hope you are in a place where you're staying nice and dry. And Happy New Year. This is, I think, the first workshop of 2026. Glad to have you, everybody here. I, like Julie, was very interested to see some of the questions, really good topics that I hear in the clinic all the time. I'm a nurse practitioner. Veronica and I see patients. Once the genetic counselors do their counseling, we take up the reins and help our patients with their screening and risk reduction for as long as they can put up with us.
Veronica.
I am Veronica Fern. I'm a nurse practitioner in the Hereditary Cancer Clinic, working alongside Beth. And I'm sure as she is, I'm very grateful for our genetic counselors who do such a fabulous job of answering questions like these that have come up tonight. And we also occasionally have them asked of us. And so we have a very close relationship with our genetic counselors. Who are very supportive of us and our patients. So yeah, I'm happy to be here tonight.
And I'm Pamela Munster. I'm the founder and physician of the Hereditary Cancer Clinic. And right now, this is really a testament that you don't have to go on a webinar if you have personal questions. You can come see us. Clinic visits are meant for you to provide you with care, the screening recommendation that you need, and the updated information that this field has seen over the last few years. I think, Julie, I think we have come a long way, and what's changing in the recommendation for how we screen and how we approach individual with hereditary mutations. But let's go back and Julie, give us the genetic underpinnings of hereditary cancer mutation, and what's the biology in someone layman's terms?
Yes, I think I will start off by saying I think that those words make a lot of people anxious or worried. We know that cancer is a very serious disease that affects a lot of people. Most cancers actually don't come from things that are inherited in the family. They come from the natural process of aging and things that our bodies go through as we go through life. But there are a small group of families, not that small, but a minority of families where we know that there is something being passed down through the generations that makes people's bodies more susceptible or more likely to develop cancers. And that, as I said, is something that isn't easy to talk about, but we are, if we know about that by doing a genetic test, which is looking at the things you inherited from your mother and father, if we identify something there that tells us, oh, this person, their body's not as good at preventing cancer as the next person, they're more likely to develop cancer, we can take that information and watch them really closely. That's why, as you said, Pamela, we've come so far in the last 10 years We had all these scattered resources that were really hard to navigate, and now in the last 10 years, it has made such a difference to be able to say, if you have this type of inherited risk factor, yes, we take it really seriously, but there are people like Beth and Veronica who will take care of you, and as Beth said, take care of you for as long as you'll have us, step by step. So I think that maybe to try to wrap up what I'm saying, we're really talking about some families where we have identified something that makes their bodies not as good at preventing cancer. And as much as that is serious information, it's also information that we can leverage into a really personalized, intensive monitoring and prevention plan.
Okay, that's actually really helpful. And you and I talked at length about this, right? While it's really scary to have a genetic mutation, we actually know what to do about it. I think often I'm faced with a young patient who had a mother who had breast cancer at 45. But the mother had no hereditary mutation and nothing that made us clearly link her cancer to any cause. For the daughter of that mother, we really have a hard time determining what the recommendations are. So she has a family history, but we don't know what the risk is for the family members. Whereas if someone has a mutation, then the kids have a 50-50 chance of inheriting the mutation. If they do inherit the mutation, we have them seen in our clinic and make very sophisticated screening recommendations. If the patient doesn't have the mutation, then that risk is very much reduced. So I think there are really advantages. It's like, so then Julie, why is not everyone getting tested? And I know I'm putting you on the spot here.
I I think that we are moving in that direction, and maybe not as fast as some of us would wish, but I do think we're moving in that direction. Many times we can tell which families are more susceptible to cancer because of the pattern that we see in that family of multiple people with cancer at earlier ages. Other times we can't tell. And either it's a small family, a family that doesn't talk about medical things, a family where their relatives died early for other reasons. And so our focus on family history is a limitation. We are missing families that way. And I think it's just a matter of time that we keep expanding it. I think some of the barriers that this team is working to overcome is making sure that people are well informed about what the test is and what it could tell them, and properly connected to the resources afterwards, like Beth and Veronica. So we don't want to be giving people this information in a vacuum. There's also, which is a little bit beyond the scope of today, but I think there is some trickiness in interpreting the risk, maybe not for some of the genes that we know better, like BRCA1 and BRCA2 or the Lynch syndrome genes, but certainly for some of the genes that we are still learning about, like ATM and CHEK2. Those were first identified in families with a lot of cancer, but we now find them sometimes in people who have no cancer in their family. And so this is not a reason to stop testing, but I think it's something we have to be thinking about as we expand testing, is what is the appropriate screening for people who have some, a genetic, what we call a mutation or a problem in one of these genes, with not a lot of cancer in their family. We want to screen them appropriately. We also don't want to over-screen them, which would potentially lead to additional costs, additional medical procedures, a lot of additional worry. So that's the delicate balance, I think, that we're all working on. So I agree that we do want to keep expanding testing, but to try to do it as responsibly and thoughtfully as we can.
So let's delve into the specifics a little bit, and let's go to BRCA1 and BRCA2 first. So Beth, the patient has been diagnosed with a BRCA mutation and she is 25. What happens next?
So for individuals who come to us who are 25, the first thing that we talk to them about is breast cancer screening. At 25, we start with breast exams every 6 months, and Veronica and I will talk about how to do breast exams, what to look for, when not to do breast exams. And then we will also schedule them for a breast MRI. Breast MRIs is the first type of breast imaging that we do. It's very good at finding very small things in breast tissue. And we will do that annually until she's 30, and then we add more.
And that's different for BRCA1 or BRCA2?
It's the same for BRCA1 and BRCA2. We start with the MRI at 25.
Okay. And Veronica, now you see the same patients in your clinic. She is 21, she has a BRCA1 mutation, and her sister is 27 who doesn't have the mutation. What screening does the sister need to do?
It sounds like she's already been tested.
She's been tested and she's negative.
So she would be screened based on her family history of breast cancer. If there's a lot of breast cancer in the family, the genetic counselor might recommend that she see a breast oncologist to do the calculations and so forth that are available to try to hone in on her risk.
Now, but her mother has I think that's what brings the complexity for this case. So let's assume the mother of this 27-year-old who does not carry a BRCA1 mutation has a BRCA mutation. Now, the daughter doesn't have a BRCA mutation. So she is not as much at risk for breast cancer and is probably not as much as risk for the BRCA-related breast cancer, but the risk is not completely zero. So I think what this really speaks to is very complex. Are the breast cancer truly linked in the family, truly linked to the BRCA mutation, or could there be another cause? If we as a group feel like the breast cancer is mostly linked to a BRCA mutation, then screening is fairly minimal, and we start with a mammogram at 40, 45. If we think there may be, and sometimes we see this, sometimes someone has a BRCA mutation on breast cancer, but they have from another side of the family, they also have breast cancer. So then we tailor the screening. So this 27-year-old, even though she's BRCA negative, should probably have a consultation with us and be reassured that she probably doesn't need to start this early. Now, if you have a sister who's 25 and doesn't want to get tested, Julie, what do we have good recommendation? What to do next?
Absolutely. I think that happens. So as you this hypothetical family that you're talking about, we know three sisters can have very different views on things and can have very different genetics. As Beth just told us, 25 is the age where if we knew that their sister had inherited that BRCA mutation, we would want to offer her some extra breast cancer screening. What I would suggest there is I would really encourage that sister just to come in and have a conversation with a genetic counselor. I think that a lot of people feel like they have to figure it all out in their heads or with their friends or with their family and then walk in and do the test. And some people do. And if that's what they want to do, then I'm here to help facilitate the logistics of the testing. But there are other people who really want to hear what this means, who want to have the comfort of knowing who their team is. And so I would first encourage the sister just to come in and have a conversation. And if at the end of that conversation she decides, I just really cannot, I'm not ready to look at a piece of paper that says I'm BRCA positive, it's just too overwhelming, then I would say, you know what, go chat with my friend Veronica. She can do a breast exam for you. She could talk to you about the option of breast MRI. We do have a few people who've done that with all the pros and cons. Yes, they didn't have to face that information, but there was a 50% chance they did a breast MRI that they didn't need. and maybe something was found on that needed a lot of follow-up. So it is not there's no perfect answer, but I think that would be my thought is first, would you be willing to just talk it through? And what are the things, I would ask them, this is scary. What are the things that you're most worried about? What do you, and try to address those. And as I said, if they're not quite ready, then, and we do still offer screening, but I know Beth and Veronica would be kind of cautious about the hazards of over screening if you might be a true negative.
So I think what you're hearing from my team members is, even if you're not ready to be tested, we'd be happy to take care of you. And sometimes testing takes multiple conversations. Sometimes it takes time and be in the right place. It's like sometimes surrounding circumstances are really, really stressful, and knowing about the mutation is not the right time. Mostly nothing catastrophic happens when you wait another year, as long as you're like carefully screened and see us and know who to call. You may have a findings. At the same time, it's like if you're the one in the family who's negative, that sometimes also takes a visit, because it's not completely intuitive that the risk is now zero. It's not zero, and as Veronica pointed out, it's like this deserves a conversation. And often this is very, very reassuring that if you know that your mom had breast cancer at a young age because of a BRCA mutation and you don't have the mutation, it's quite reassuring. Doesn't mean you never ever need to be screened. So I think what we're trying to do is try to take care of families. Let's talk a little bit about, okay, we're staying with BRCA1 and BRCA2. When do we test the brothers? Julie, maybe you can take that.
Yes, I think when the question comes up, which we had a lot of these questions submitted about timing, I think about I can definitely give the numbers, and I will, but I actually think that the sort of like, what are the guiding principles is we want someone to be tested before they would use the information. We want them to have the information by the time they need it medically. And so for someone who is born male, and we think about cancer screening, and the cancer screening guidelines mostly start around age 35. So there's a little bit of time there. We also think about having children, because when we have children, if someone is BRCA or BRCA positive, there's a 50% chance of them passing that on to their kids. It doesn't have to change the way they think about having children, but for some people it does. And so I would say the latest that someone who is born male would be tested would be either 35 when they need some cancer screening, or if they're thinking about having kids, they might want to do it. Certainly there are people who want to test earlier. And so then I think, what is the lower age limit? And because thankfully we don't know of any cancers caused by BRCA1 and BRCA2 in children, we would typically say that we would want someone to be a legal adult over age 18, and then in that age range between 18 and 35. And we were kind of chatting a little bit before we started the webinar formally, like you meet people who have every sort of thought process about that. The people who come in, on their 18th birthday, and the people who still don't want to do it when they're 35. And so I think that's where just sharing the information, being available to have a conversation is what I would recommend in that age range, so that each person can kind of get to the timing that's right for them.
Great. And then Bess, if you have a 35-year-old with the BRCA2 mutation who is born male, what are the recommendations?
So at 35, the first thing that we would talk about is male breast cancer. The risk of male breast cancer is not really high, particularly in BRCA1 males. The risk is not very high. But what we do is teach them how to do self-exams. men are not always familiar with what part of their chest wall is breast tissue versus muscle. And so we help them identify easily what part of the tissue that they're going to be testing, checking, and really, I suggest to men that they do it in the shower as they're bathing. Uh, if it's a male who has BRCA2, I would be talking to him about dermatology exams. There's an increased risk of melanoma in individuals with BRCA2, so I'd be talking to him about establishing with a dermatologist if they have not already, and getting annual exams. And there's no screening for prostate cancer at that young age, but I would talk about some of the symptoms to be on the lookout for prostate cancer. Just so if they have some changes in urination, they are, and those changes become persistent, they're just aware of it. And we tell them, when in doubt, contact us and let's go over the symptoms and talk about whether or not it's something that we need to do some testing on or not.
We could also offer them a baseline mammogram in case they ever develop some symptoms of a lump or so forth, and then the radiologist would have something to compare to the new findings. And we begin talking to them about prostate cancer screening because it does start at age 40 rather than later in the 50s for the general population. So we prepare them for that and discuss, the implications.
Yeah, more than anything, however, it's like, I mean, while not a lot of things happen for young males under 40, but sometimes things do happen. So if you're like a mutation carrier and you find a lump on your neck, please don't ignore that. Seek our attention. And I think, and often we are very good providing reassurance when something is just fine and it's just an abnormalities that probably has no medical consequences. Please don't have many, many sleepless nights at home without looking for us, so we can reassure very quickly. And if something we should worry about is, we want to not wait until it gets bigger. So I think, and many BRCA carriers have other reasons to have lumps and bumps, and that are often benign. It's like, but should not be neglected. So going back a little bit of like, yeah, but Julie, so where do you get tested? Let's say your sister has a BRCA mutation, she lives in Seattle and you live in California. Well, how do you go about getting tested? You had to fly to Seattle?
I would love to go see the Space Needle. But so there are multiple ways to get this test. And I know that's one of the questions here. And in terms of finding a resource, so if you're in the Bay Area, we are here for you. Even if you're, throughout Northern California, we are here for you. And I think one of the questions submitted was really about the costs of transportation and things like that. And there are some variations with insurance, but most of the time we can do genetic counseling through video if that's what is better for somebody. I love seeing people in person, but if it's better for them, we can do it by video. So I'll start with that. If we talk about another area like Seattle, then I think there are a few different ways we can go. We can certainly, there is the National Society of Genetic Counselors actually has a directory where you can look up genetic counselors. But a lot of times what I tell people is to say, go ask your primary care or ask your OBGYN, because they'll have their normal go-to people for cancer genetic testing. And I'm mostly talking here about doing this through genetic counselors because that's what I'm used to and that's what I do. And we're always happy to talk to people. I think especially there's maybe a little bit of added value in for those people that you mentioned who might be very hesitant, or who might be quite young. So they're just at the very beginning of the age where they could consider testing. I think that's where we might want to just build a little bit more of a support network around that. But I do know that a lot of OBGYNs are very familiar with this testing and are doing it in their own offices. So that will sometimes come up for people. And then, of course, we're here mostly talking about family members who hopefully have not had cancer. But in our cancer center, I know that you, Dr. Munster, and your colleagues will often order testing directly for people as well. But if we're thinking of those sort of young, healthy people who might benefit from a more in-depth conversation and more kind of robust support, then I would say look at the National Society for Genetic Counselors, or ask us, and we might know a colleague there, or ask your regular doctor, because they usually have, or nurse practitioner or PA, your primary care provider, because they usually have their kind of go-to people that they would recommend.
Now, of course, I want to do a little bit of personal coloring here. Of course, many of the mutation carriers, when they find out that they carry mutation and they have children, they go like, oh my God, could have passed this on to my children. And I remember vividly when I was first diagnosed, all I really wanted to know, did I pass this on to my daughter? My daughter at that time was 8. And I really, really wanted to get her tested. Not because I thought there would be anything that would happen differently to her, but I just wanted to be reassured that I didn't pass this on. Now, the problem is, like, once you test your child, which I really, really strongly recommend against, right? You then really can't really sit on that knowledge, right? Particularly if you have multiple children. So I'm just walking you through what happened. So I had 3 children. I really wanted to know whether my daughter carried the gene. And then I could have tested her, because I definitely have an ability to do this. But then I figured, like, well, how would I keep that secret? If she is positive, I mean, I can't really tell my 8-year-old that she's positive. And if she's negative, could I really let her go through life and not tell her that I know she's negative? So that put me on a lot of quandary, and I struggled for weeks with this. I also then thought, like, but I have 3 children, so the chance that at least one of them is positive is high. So if I know the results of one, what I do with the other one. So I think to make a long struggle very short here, don't test your children. Because what I learned as my children grew up, it's really important that they can get tested when they're ready. When they're in a good space where they know how to deal with the mutation or the results, or not having it, when they're just in a space where they're ready for it. And I think everyone with a mutation at first thought is, oh my God, did I pass this on? And I think, but don't get your children tested, because it is very difficult to not divulge the knowledge if you know that your children are positive and not tell them. So,
may I just respond to that a little bit? I always appreciate your openness in sharing that, because I think we, on the one hand, I agree with you that we don't encourage the testing of children, but also that is such a natural instinct. As you said, like, as parents, all we want to do is protect them. And we, I think a lot of parents feel guilty, even though you don't pick your genes, you feel like, oh, did I give this thing to my kid? And your head spins out, how it is, like, to 20 years from now, then this and then that. And so I always appreciate you sharing that story, because I think it really acknowledges, like, how natural it is to have that reaction. But also the fact that, we already are weirdly protective, and I think about having, for those of us who've seen our kids through all these stages, we know, like, there are big things that 8-year-olds have to deal with, and there are big things that 12-year-olds have to deal with, and big things that 16-year-olds need to deal with. And this is actually, thank goodness, not one of the things that they need to deal with yet. And I would rather that as parents and as developing humans, that they have the ability to focus on the things that make sense at that point in their development without being distracted by this other thing. And then, as we said, you gave the story of this family, even though it's made up. We all met those families where the three sisters all had really different decisions. And we look at those 8-year-olds and we say, we don't know which of the 25-year-olds this person is going to be. Are they the 25-year-old who wants to run out and get tested right away? Or are they 25-year-old who's really, really hesitant? And we don't, it feels like a big thing to take away from them at age 8, to be able to figure out who they want to be when they're 25 and how they want to go about that. So I always appreciate hearing you tell that story, just because I want to acknowledge like the parental protectiveness and how just automatic of a reaction that is.
And even like how they react to the knowledge. If they are positive, a 20-year-old deciding, oh, I'm not going to have any children, I want my ovaries out now, that kind of thing, where developmentally, maybe they're not really ready to make that decision.
And I think that there's no real need to have. I think this is the again, what we're trying to build with this clinic is like, it's quite a natural instinct if you're 20 and you have a mutation and there's risk for ovarian cancer, that you want to give up your ovaries, because at 20 your needs or wants or wishes for children may not be there. And I think a big part of our clinic and our care is to reassure the likelihood of ovarian cancer at 20 is very, very low. The decision making for taking the ovaries out at 20 is probably something that can be delayed. So I think just buying people time and reassurance is what we're hoping to be here for. Going back to the testing is like, and there's of course always a couple of questions like, and Julie, you mentioned this before, there are children we do want to test because it directly impacts how we screen. And I think, Julie, if you can talk a little bit about maybe leishmania and some other genetic mutation where testing children is actually important.
Yes, thank you. So that's, as you said, I sort of alluded to this earlier, that we do have all these numbers, but it's really about the principle that we want people to be tested before they develop cancer from their genetic risk, so that we can intervene with early detection and prevention. And so for many of the hereditary cancer conditions like related to BRCA genes, Lynch syndrome, these are adult onset. They are risk factors for adult onset cancers, and that's all the things we just talked about. We test adults. However, there are some inherited risk factors for cancer, like in the gene TP53, which causes, as you said, leishmania syndrome, where we can see those inherited mutations cause cancer in children. And so there, even though, again, nobody, wishes that they had to think about this, that we want to know that before anything happens. And I'll insert in here, I'm not in the business of convincing people to do something that they don't want to do, but I am somewhat in the business of trying to balance that sort of pure gut fear that a lot of people have with some perspective. And one of the things I think about is it is really, really hard to do a genetic test and get a positive result. And it feels really frightening, and it does not feel good. And yet nothing actually happened in that moment. We are born with the genes that we have. From the moment of conception, we have those genes. And as if that is what someone has inherited, as hard as it is to do the test and get that news, I would rather that they find out from me by spitting in a tube than they find out by being diagnosed with cancer, maybe being diagnosed late with cancer. So again, I don't say that to try to strong arm or scare someone, but just to remind us, like this thing that we don't want to see, we don't want to see it, I don't want to think about it. If it's there or it's not there. And if it's there, I would rather that you know ahead of time and know by doing a genetic test than find out a harder way. And that's true for even for the those families where there is a risk of childhood cancers. Again, like none of us as parents, as humans, want to think about that. But if that's the risk they have, it's actually like such an amazing opportunity. We used to, when I started a long time ago as a genetic counselor, we actually didn't do a lot of testing for TP53 because we didn't know if we could help people who had Li-Fraumeni syndrome. And then about 15 years ago, some researchers in Toronto said, what if we just threw every single test at these people? If we gave them whole body MRIs and brain MRIs and blood tests, could we actually change the outcomes of this very serious condition? And it turns out that we could. And that is really what has changed about 15 years ago, where we said, even though this is really hard, if we know about it, that first study showed they were diagnosing stage 1 cancers instead of stage 4 cancers. And that's what we've been doing more and more, and what Beth and Veronica do, every day.
And I think that's what we found for breast cancer, right? If we did MRIs, we diagnose cancers often when they're stage 0, sometimes even in a precursor state, and definitely at a much smaller stage. So going back a little bit is like, and there's a couple of questions that I'm going to answer. So let's say you have a child who really wants to know. My son, I think, was 18 or 19, and he just wanted to know. And I had a long conversation with him, what it would mean that he knows, and how I would hope for him, if he does know, that he would not share with the rest of the family. And so he got tested, and his brother, who's a year younger, did not get tested for a while because he wasn't interested and it didn't bring it up. So of course, it's not the early morning question, hi son, do you want to get tested today? It's more like the kids bring it up, we address it. So my second child got tested about 3 or 4 years later. And as I said, my oldest son just wanted to know, and he's very mature. Then for my daughter, she wanted to get tested, and I had to deal with her. She needs to get through 1 year of college. Because I did not think it was particularly easy to be away from home, away in a new environment with not clearly established support system, and learn about the diagnosis like this. And needless to say, she was the first day home from college, and she got herself tested. It's like first day after she finished the first year. And so I think kids are all different, and as parents, you know your children really well. I mean, be a guide, and help them make good decisions and be there when they need it. And a lot of the time at 21, we don't act on it, but at the same time, a girl who is positive, who has to look at a lot of testing starting at 25, having a little bit of preparation before this starts, and having a little bit of time where nothing is really going to happen is really helpful. I think it's hard to have a positive test and then start embarking on multiple screening right in the same year. Another question is like, my daughter's 18 and wants to get tested but scared about insurance. And we talked a lot about the GINA Act. Julie, you may not want to talk about this. It's like, what it means if you're positive. Does insurance deny you? It's like, can you not reveal your mutation? Do testing agencies ever dump your results? Testing agencies actually don't report your results, but they don't dump it either.
I think this question comes up a lot. So you mentioned GINA, which is the Genetic Information Non-Discrimination Act. It's a federal law from 2008. That's a federal law, and I think 48 out of the 50 states have their own state laws. These laws are protection against insurance discrimination for health insurance. And the question that was posed did, sort of ask about that. So there is significant protection for discrimination against health and for getting health insurance. So testing positive, you're quite well protected. There are limitations to that. People who are like self-employed or work for a company that's under 15 people, like things like that, there's a few gaps. But generally speaking, for health insurance, we are very well protected. The areas that are not as well protected are the types of insurance that some people might think of as a bit more optional insurance, like life insurance or disability insurance, which does lead some people to ask the question that was posed is, could I be tested anonymously? My answer to that is always, I will help you do whatever you decide you want to do, but let's walk this through step by step. What you're worried about is a positive result. If you have a positive result, you might need some cancer screening, like a breast MRI or a colonoscopy. And the only way that you're going to get a breast MRI at 24, 25 is if you show that you are positive. And so in some ways, that anonymous result might need to come back into the system. And the other thing I will mention is for the life insurance and disability insurance, that sometimes they aren't just looking at your records, but they might ask you a questionnaire. And at the bottom of that questionnaire, one of the questions might be, have you done testing like this? I've done or tested positive. And at the bottom of that questionnaire, you have to sign that says, everything I've said is honest. And if it's not, then you can void my policy. So it's quite hard to get around it with anonymous testing. If somebody said that that's what they wanted to do, they could try to do that, but it's quite hard to get around it. And there's actually very few companies left where you can order your own genetic test that's good. There's a lot of companies that will try to sell you a genetic test that is not good. But actually the two companies that we used to refer people to order their own testing are no longer doing that. And so I'm happy to talk to anybody individually, but generally I would say overall, you're well protected from a health insurance standpoint. Sometimes what we say to people is do you want to go get a life insurance policy or a disability insurance policy now? And it's probably pretty cheap for a 20-year-old. And if you don't need it, you can, get rid of it. But the anonymous testing rarely feels like it's the solution to me for the reasons that I mentioned.
And I think at the same time, it's not all insurance companies cover all preventive measures. I think if you do have a genetic mutation and it's open enrollment, look at the insurance companies and look what they cover. There's the mandatory preventive screening is not covered by every insurance equally. So this is a good time to look at what the different policy does. And particularly if you do screening, look at what the deductible is. If you have a very high deductible, if you go to screening, you may just pay the entire deductible, because remember, when you have a $4,000 deductible, $4,000 have to be spent first before you get your tests reimbursed. And I think we have insurance support at UCSF. We have talk to us in the clinic. As a lot of these things, a lot of the questions we have addressed before, we may have an answer to.
Can I just there was a follow-up comment about the laws potentially changing. And so I just wanted to speak a little bit to that. I certainly can't promise that they won't. That's not something that's within my ability. But I do point out a few things when people bring that up. I think one is that federal law passed in 2008. The number of people who now know that they are positive is orders of magnitude greater in 2026 than it's in 2008. So I think the constituency that has an interest in that being protected is actually quite a bit larger. So I think that is one hopeful thing, and bipartisan. The genes don't know which way you voted and don't care. The other thing that I try to balance this against, and I think this is relevant to the age question, is if somebody comes in and they are a 32-year-old person who is a woman born female whose mom is BRCA2 positive, I would acknowledge all of the potential concerns. And I would also say, I can't promise you what the laws will be in the future, but I can tell you that if you are positive, it is very, very, very important for you to be appropriately screened right now. And so we don't always get to pick a path where everything is safe and good. And so if someone is at an age where they really need to be screened, I would put the worry about the laws changing a couple steps down. If somebody is 18, a person born male who's 18 who might not need this till they're 30 or 35, then you might say, oh, okay, well, let me just give this some time and see what happens. So I do think, we don't always get to make a decision with no risks, but I would say the risks of the laws changing is lower than the risk for some people of getting a cancer. And so I would keep that in perspective. So I can't promise. I think that the fear is real, but I am a little bit hopeful. And I'm also a little bit urging people to balance, what the pros and cons are.
Okay. I also feel like most insurances recognize now that screening for breast cancer is still much cheaper than treating breast cancer. And so I think as we will see in the future, I think this clearly life saved. It's a lot less expensive to do an MRI or mammogram for breast cancer than treating breast cancer. So I think yes, Julie's right. Laws can be changed. You all have reasons to worry, but these are uncertain times. But not having a big tumor at 35 that could be prevented is really my main goal. And unfortunately, we all have been there. So now let's talk a little bit, and this is one of the questions of one of our participants. We say pancreatic cancer doesn't happen until 50, and we don't start screening until 50. But what if you have a family member who died at 40 with pancreatic cancer? How much, Veronica and Bess, how much do you take the family history into consideration when you make recommendations for screening?
Beth?
Sure. So generally speaking, our patients have already seen a genetic counselor in our clinic, and that's one of the most important things. They do a lot of important things, but one of the important things is they really look at family history and talk individuals through cancer patterns in their family, who's been tested, do we know which side of the family that the mutation is inherited from? So for example, if somebody had a relative who had pancreatic cancer, but it was on the paternal side of their family, and they had inherited the mutation from the maternal side of the family, then that pancreatic cancer is important, but it's not related to their gene. And so Julie and Marta reason that through with people so they get a kind of an idea of how to put perspective on that. So by the time that we get them, we already kind of know which side of the family we're looking at. So let's say it is the side of the family that the gene is inherited from. We generally will talk about starting screening 10 years before the first diagnosis in the family. So if somebody had a relative that was diagnosed in his 40s, potentially he might start screening in his 30s. Often we will refer people for a consult with our GI department. There are some of our GI folks who are experts in pancreatic cancer screening. and they can help talk through the pros and cons of starting screening at a young age. But really, family history, if it is the side of the family where the mutation is from, is really important, particularly with pancreatic cancer, when considering how to do screening for the person in front of us.
Veronica, anything to add?
With pancreatic cancer, what I'm finding, because it usually occurs late in life, a lot of people don't know that, their family had some kind of stomach cancer. It's vague, and people from that generation didn't necessarily talk about cancer. So sometimes if the person has a lot of worry and there are these more vague diagnoses in their family, we'll still send them for a consult to get, the GI opinion. It can be very reassuring, but, also help us hone in on the risk a little more.
Okay, so then the next question is like, how do we do pancreatic cancer screening, and who should get pancreatic cancer screening right now? Are there particular syndromes and like did I just lose you guys?
ATM and BRCA.
Well, there's a couple of genes. The most recent changes were for BRCA2 and the ATM gene. Previously, the recommendation was to do screening if somebody had a family history of pancreatic cancer. Recently, when was it, Julie, last year? There was a change in the guideline, and they extended screening to anybody who had BRCA2 or ATM mutation, regardless of family history. For BRCA1, on the other hand, there is still no recommendation for screening unless there's a family history. And that's because the risk of pancreatic cancer for people with BRCA1 is lower than it is for BRCA2. There's a whole other set of syndromes that Julie can pull out of the top of her head, where pancreatic cancer risk is high enough that everybody with that gene will get pancreatic cancer. Julie, you want to help me out there?
I was trying to type an answer to someone else, but CDKN2A, which is a melanoma pancreatic cancer condition, and I think STK11, which Pamela was talking about when we were chatting beforehand, which causes a condition called Peutz-Jeghers syndrome. And both of those are more rare, but those are two conditions where the pancreatic cancer risk is actually higher than it is even for the things we see more often, like BRCA, ATM, and Lynch. So CDKN2A and STK11, where we screen everybody, starting at age 40, I believe.
And just to add a little bit more on the screening, the standard of care for screening is once a year, having one of two different procedures. One of is a special kind of MRI of the abdomen called a MR choliopancreatography, or MRCP, which looks at the pancreas, the liver, the gallbladder, and the interconnectivity between those organs. And then the alternating screening is a different type of procedure called an endoscopic ultrasound. If those of you who are familiar with endoscopies, it's the same type of procedure, except instead of looking for ulcers in the stomach or any kind of problems in the esophagus, they actually can ultrasound the pancreas through the bottom of the stomach, through the floor of the stomach. And one of the handy things is we can actually ask the GI department to schedule the endoscopic ultrasound at the same time somebody's getting a colonoscopy if they're due for one, so that you kind of get two procedures for one sedation.
And there's a question that often comes up is like particularly for women who have breast MRIs and pancreatic MRIs, can it be done at the same time? Theoretically, yes, but that's a compromise on both images because the way we give the contrast is somewhat different. So while we of course don't want to be dogmatic and not say they should never be done together, we do feel like as much as possible, we try to have the MRIs of the breast and the MRI of the pancreas done at different times. And then Veronica and Elizabeth, like how we feel about the endoscopic ultrasounds and MRCP? Do we alternate? How do you handle this in clinic?
Well, that is the official standard of care. That's what's recommended. That's what the GI docs usually recommend. We have patients that just want to do the MRCP because it doesn't involve sedation. It doesn't involve having someone drive you home, as an endoscopy does. So sometimes they just want to stick with the MRCP. We actually have a big conference coming up, and that's one of the questions that we're asking of the pancreatic cancer specialists. Would it be okay to do the MRCP and only do the endoscopic ultrasound if there are suspicious findings? Because the MRCP is very sensitive. It's 95% sensitive, meaning good at finding cancer. So that is something that's a topic of conversation right now.
I think to put this a little bit more broadly, we take anyone's preferences and special circumstances in consideration. Data-wise, we don't have clarity around MRI is better, ERCP is better, EUS is better, alternating is better. We still in a very steep learning curve from like how pancreatic cancer is detected early. How much benefit do we have? It's like we're really depending on you to participate in studies and come for screening, but we don't want to be dogmatic. And we also recognize that if you're 50 and like you're likely going to live to 90, that's a lot of screening. And it's even more screening when you're 25 and you're looking at MRIs and mammograms on the breast for many, many years. And I think there's a lot of recent publication that a well-screened BRCA1 and BRCA2 population without the mastectomy has a very high chance of not compromising their survival. They may have a high risk for breast cancer, but not necessarily compromising their survival. But I think a big part is really like, what's the burden of screening? And I think when we talk about screening and survival and benefit from screening, what's often not taken in consideration is the toll that screening brings, like the waiting for results. What happens when it's false positive? What happens when you get the screening done on a long holiday weekend when no one looks at your films for 5 days? So I think a lot of the anxiety around screening is still not completely solved. I want to go back on some of the question that often comes out. So if you had a test
in Raphael, you'll see clouds with a chance of showers and can expect a high of 50.
If you had a test that included a 30 gene panel in 2020, Julie, do you need to get retested in 25?
The
cancer, and the reason why I ask is because in the cancer world, we do a lot of the tumor genetic testing gets repeated all the time. So why not the germline? Can the germline not change?
Yes, so that's a great question. As you said, tumors, first of all, just the word genetic tests, if you're in the world of cancer, it's so confusing because there's so many different ones. Germline, as you were saying, is the way we refer to the tests that are look for what is inherited. So they're not the genetics of somebody's cancer, but the genetics that they were born with. It's usually done on a blood sample or a cheek swab or a spit sample. And those results will not change. So that I would not repeat them because I think the results are going to change. The times when we do more testing would be if we think that the test didn't give us all the answers and we need to do a better test. And I saw one of the sort of submitted questions was someone who tested positive on a big 80 gene panel, and then their family member was tested with just 2 genes. My answer to that would be twofold. I think as long as the gene that you tested positive for was on your family member's test, that's generally a good sign. We get super particular as genetic counselors. We're very nerdy and picky about this. I actually like to see the report because even though there are so many good laboratories, sometimes one laboratory finds something that another one doesn't. Or there are some results where one laboratory calls it normal or uncertain and another laboratory calls it positive. So I love to have the side by side of test results. But in answer to that other question, generally that we would expect that if your mom was tested for BRCA1 and 2 and you're BRCA2 positive, that was covered with the little caveat I just gave. The only reason, the times when I might go and do a bigger panel for someone would be, do I have another question? If she was only tested because her daughter's BRCA2 positive, but she herself is fine and all her family members are fine, then the chances that there's something else is not very great. So I might have liked to have gotten more information just to get it while I did it, but it might not be worth going back and retesting. But if she had 3 uncles with colon cancer, then you should definitely go back and do more. So it's a little bit looking at the whole picture. But I would say I tend to repeat it if I think I've missed something, like there's more family history that hasn't been explained. And I'm less likely to repeat it, even a test from like 2002, if we're like, this probably explains everything that's going on. If I've offered, if you want it, I'm happy to order it for you because who knows what we might find, but I'm less worried about it, or like, I'm not necessarily going to be the one to advocate for doing more testing.
Okay, if a person has a BRCA1 mutation, do you want to test the mother? Do they need to do a full panel, or can they just do BRCA1? How do you handle family testing? So do we do a full panel? Do we do selective mutations?
I think, yeah, that's a little bit what I started talking about is we will look at the individual situation. These days, I will say, just because logistically it's on the same sample and it's billed the same way to insurance, that we will often offer people panels. But the need, like how driven are we to do this, depends on the family history. So if, as I said, if somebody's BRCA mutation looks like the types of cancer in the family and the people who've tested positive, we think that's the stories, the question has been answered. It's less important to do a panel. And going back to something we were talking about earlier with the people who like run out at 18 or 19. Again, I'm not here to withhold something from them, but I might be a little less like encouraging of the panel because here's what I'll say, if there's no indication, because it's already a lot of information to get, whether you're positive for what your mom has or doesn't. The other thing is if you're 18, like if you're my age, if you're in your 50s, and I do a test, I'm like, this is probably like the information I'm going to need for like a lot of my life. If you're 18, I can promise you that there'll be a better test by the time you're 30 or 35. And so you're really not getting the same kind of like, I took care of this question with a panel. If you do it at 18, then I am. So we do offer the panels, but I would say it's an option for most people unless I see something else in the family where I'm like, oh, I really should make sure we're not missing something. And I do think about the age and just how big of an impact that main question of do I have what my family has or not already looms for them. Some people want to get more. I will always follow their lead, but I think it may be more appropriate often to do focus on the family mutation for young people.
So then one of the so now it's we reached 6:30. It's like I think we now will focus a little bit more on the participants' questions. Feel free to write in if you have any specific questions, like even if they may not be totally in line with the topic, that's fine. Couple of questions. Now, who orders endoscopic ultrasound? Who orders that, Veronica?
Sorry, I muted myself because there was noise here. We do. We can order it, or the GI oncologist can order it, but we often order it.
So many of our patients actually don't have a GI oncologist or gastroenterologist, and I think if you're plugged into our clinic, you're probably okay, particularly if you have a hereditary mutation that spans multiple cancers. We try to do all the screenings. And then our clinic does really make sure that we do all the screening. If you have a prostate cancer or like any cancer, we then refer you to a specific oncologic discipline. So we don't actually treat the patient's cancer in our clinic. Okay, it's a question. My daughter will be 32 in May, was told back in November is to wait until at least April for testing. I'm not sure what to say. There's no reason to wait to a specific time there, but sometimes the recommendations are there's an insurance change, there's a change in approach, or there's something else happening. So Julie, there's anything I'm missing here, you think?
I think what she might be getting at, which I feel really bad about, is the wait time for an appointment. That there are people contacting us in November who are being offered appointments in April. In answer to your question of what is involved, as I think you've kind of heard us say through this, like there are people who are just like, I just want to get it done. I know everything I need to know. I have no questions. And there are other people with a lot of questions. So the wait is probably to see a genetic counselor. I think that's what the question is saying. So first of all, I acknowledge that is really, really hard. If somebody wants to be tested more quickly, they might want to check with their OBGYN. But I understand it's hard to wait, asked to be on a wait list. And also to know that even though it's very anxiety producing, that we will, get to them. And sorry, I'm seeing the follow up. I'll just buy the damn thing if that's how it is. So what I would say is, unfortunately, as I said, the companies where you could buy a good test are no longer doing it. There is not a company I can currently recommend. What I can tell you though is that multiple people in our group are launching what we call cascade testing projects. So we are trying to have an expedited testing available to people whose family members have tested positive. It will not involve any appointment with a nurse practitioner or a doctor or a genetic counselor. It will involve filling out some forms. And of course, if somebody tests positive, we would want them to see a genetic counselor, and a nurse practitioner, and a doctor. So yes, I do acknowledge that the wait is quite long right now. Please do not. We have seen people throw away hundreds or thousands of dollars to scams online. But we can, Lou, maybe after this, we could send out to anybody who's registered some of the information about our upcoming cascade testing projects. We can get expedited testing. There is no appointment or sort of support around that, but I get that for some people that's all that they need pre-test, and then we will take care of it afterwards. So yes, we'll try to help. I know the wait is hard.
And I think when Julie and I first started, like, and the tests were routinely like $6,000 and often not paid for by insurance. We spend a lot of effort in doing what we call the pre-test counseling and pre-test visit. Now, as we test more and more patients, and I really would like to test everybody. Clearly, we do not have enough genetic counselor for everyone to have a conversation on whether they should get tested and how and what. So I think more and more it will be that if you know that your sibling has a BRCA mutation and you don't have it, and you're 25 and you're male, you're probably good for, like, you don't need to see a genetic counselor at this point until you have very specific questions. I think in that sense, it's like we have a much more judicious approach to this. We're also hoping that over the next 10 years, there'll be a very significant increase in understanding and learning on what is a mutation, what does the mutation do, what is the risk for the mutation, and that knowledge being disseminated to your general practitioners, to the community, nurses, and I think just having a better understanding what it means to have a mutation. And I think so that the genetic counselors can really focus on the very specific question and challenging cases. And I'm hoping we'll get there, but in the meantime, maybe rather than wait 6 months before getting tested and just to find out that you're negative, maybe that will be an option that can be done with the gynecologist or the general practitioner.
Yeah, and I think for the people on this webinar, like we do have 2 different cascade testing projects in progress here. Cascade meaning once somebody tests positive, testing their family members. That's the cute term that is used for that. So we'll definitely send out that information as well. And I think, as you said, it's partly the medical need is different for some people. And I get it. The emotional need is different for some people. As we get that hypothetical family with the 25-year-old who didn't want to test, but the 21-year-old who had run out and done it. And so we're not intending to set up barriers. It's just very hard to know sometimes what somebody needs until they are in front of you. But if somebody feels ready, we can share those resources. We need to make it more accessible, but I've also seen wrong tests be ordered. I've seen like a lot of things that we also want to try to prevent.
And of course, there's certain times where more timely testing is relevant. If you are 40 and have a C-section planned, you find out that you're pregnant, that you're like BRCA2 positive, that's probably a time you would take the tubes out and the ovaries out. So that'd be a good time to accelerate testing, and maybe also having an urgent genetic counseling visit. So I think there's like with every medical test, we want to take the circumstances in consideration and how rapidly we need to be seen. And even for our visits, for our genetic counseling visit, we can expedite the visit for our counselor when there's really important decisions to be made. And before we close it, there's a question on how do we come about the recommended age for oophorectomy being 40 to 42, 45. I think who wants to take this for someone who's BRCA2 positive?
I can. So there's a lot of information that we have about the age at which women are diagnosed with ovarian cancer. And so when they make recommendations for risk-reducing surgery, they look at the accumulated information about ages at which the diagnoses occur, and it forms, like any statistic, a bell curve. And so the average age of diagnosis might be 55. That means half of the women got ovarian cancer before 55 and half got it afterwards. And so there's a place younger than 55 where the risk is starting to go up. And particularly with ovarian cancer, which is a cancer we don't have screening for, the recommendation will be starting at a little bit younger age when the risk is maybe a smaller amount, because we're not going to be able to screen for it. We're not going to be able to tell you when you get it until you have symptoms, unfortunately. As opposed to breast cancer, for example, you probably all know there's actually no specific recommendation for mastectomies. It's recommended that women consider mastectomies as one of their risk-reducing options, but there isn't an age at which we recommend that women have mastectomies. But for ovarian cancer, and that's because for breast cancer, we have wonderful screening. But for ovarian cancer, we unfortunately right now do not have screening. And so I don't know, the 40 to 45 might be when the risk is starting to go 2 to 5%. It might be 3 to 6%. I don't know exactly where it is, but it's where that curve is starting to go up. And the cumulative risk is going up quickly.
Just to expand on that, I actually did pull up the numbers. So the you can find a lot of studies with different numbers, but one of the biggest and best studies, which is somewhat representative with BRCA2, the ovarian cancer risk under age 40 is less than 1%. So there we're balancing and saying, hey, we don't want people to go into surgical menopause for a risk that's less than 1%. By age 50, that risk is about 2.5%. You could argue that's still a pretty low number, right? 97.5% of people have not gotten ovarian cancer. But then all the things that Beth just said also play in, where we say we don't have good tools to catch this early. We don't have great tools to treat it. Although with BRCA2, we have better treatments than for not. And that's also actually 2.5% is already higher by age 50 than the average woman who's not BRCA2 positive has in their whole life. So we will have the question was about, like, what could I do self-injectome and then wait? And we and Beth and Veronica and our gynecologic oncologist will, we're not forcing anybody to have a surgery they don't want to have, but we'll share all of these statistics and trade-offs with them. And certainly there are people who've said to us, I will run my 2% chance. And there's other people who've said, I wouldn't want to run a 1% chance. And we try to listen to them and give them good information and guidance. But that is where the number comes from, as Beth said, it's sort of where the risk starts tipping up and knowing that we don't have the tools that we wish we had for ovarian cancer.
Okay, and last question to answer is like, how likely is it that BRCA1 or BRCA2 gets both breast cancer and ovarian cancer? I think the breast cancer risk is unfortunately fairly high with both, and the risk for ovarian cancer is probably about 20% for BRCA2 or less, 40% or less for BRCA1. And so these are the numbers that it's very heavily also influenced by family history and by other factors. So I think not uncommon. Surprisingly, what's also not uncommon, a lot of our patients, female patients who have pancreatic cancer, had breast cancer in the past. There's a suggestion that these are clearly linked. With this, Beth, any closing remarks? Anything you want to add? Anything you feel like we haven't said?
I would just like to recommend to people, if your children are interested in testing, particularly teens and young adults, and you're not sure if they're ready, our genetic counselors are amazing at helping facilitate conversations to talk about the pros and cons of doing testing, and they can kind of take some of the burden off of your lap and make it a less burdensome conversation, because they can talk to your child with you or without you and talk about, what are the benefits of testing, what are the risks, why would you do it at a particular age? And so it's coming from somebody other than you, and it can make that conversation a lot easier. And they're very good at doing like joint family conversations, however you want to work with the genetic counselors. Don't hesitate to reach out. They're very good at this.
Veronica?
So I was thinking about the question about mastectomies and oophorectomies. And I've had a lot of patients say to me, I talked to this oncologist and they told me I had to get my breasts removed. I had to get my ovaries out. And I just want everyone to know that we're here to give advice and not make decisions for you. We try to give patient-centered care. We help inform you, but we understand that these are very personal decisions. We just want you to have the information you need so that you can make the decisions for yourself. And we then, if you decide to go forward with something, we will help facilitate that path.
Thank you for that. Julie.
Yeah, I think to follow up on both of my colleagues, I think as Beth said, I think a lot of the questions submitted were about these teenagers and young adults. And so I did want to second that we're happy to talk to you first about how to talk to them. I saw a question about a script, which I don't have an exact script, but I have ideas I'm happy to share. And also, once somebody's shared it with their children, we're happy to see them, again, not with an obligation to test, but with an opportunity if they want to, and no obligation if they don't want to. And I think some of us have been getting a little sentimental recently with the 10-year anniversary of our clinic. And so one thing I will say I think has really changed is it felt, even though we had various resources, it did feel a little bit like overwhelming to know that I've tested positive, and then where do I go and how do I keep track of all of this? And I think it's actually made more people, we have people come in and say, oh, my sister, sees Beth, or my brother sees Veronica, my dad sees Dr. Munster, and like, I want to be part of this. And even though, of course, we hope that they test negative, I think it feels there's more confidence and less fear going into finding out about your risks if you know you have a place to land and people who will take good care of you. And so I think that's a message for the people who were asking about, their relatives who are hesitant. I think sometimes knowing that there's something to do on the other side, and good people to help take care of you is helpful.
Yeah, and I think I really can only echo all of this. I mean, I think we all very proud of what we have created. I think it's helpful for patients. I think what we've shown is like when we help ordering tests and images and screenings get done, I think people know who to call if they find something. They know to call when someone calls them with a question. So I think we are glad to be able to do this. We are glad to be able to share our updated knowledge with you on these regular webinars and the clinic. And I cannot thank you all enough for being on this panel and for the work you do every day. So thank you with this. Have a good evening and thanks for listening.
Right.